What if the very tests your doctor is sending you for are actually the thing putting your health in danger? Today, I'm going to break down 5 routine medical checkups that after the age of 70 can cause far more damage to your body than they will ever prevent. And the research sitting behind this information is something the mainstream medical system has been painfully slow to talk about. If you are serious about protecting your health and you want the kind of honest, evidence-based information that cuts through the noise, go ahead and subscribe to this channel right now, because this is exactly what we do here every single week. I'm Dr. Berg, and I want you to really pay attention to what I'm about to share, because this is the kind of conversation that almost never happens inside a doctor's office. Not because your physician doesn't care about you, but because the system they operate inside of runs on standardized protocols that were never designed with your specific age, your specific circus body, or your specific quality of life in mind. And here is the part that I think is critically important for you to understand before we go any further. The risk to benefit calculation of routine medical testing changes completely once you move past the age of 70. This is not a fringe idea. This is documented in peer-reviewed medical literature, and it is something that the United States Preventive Services Task Force, which is the governing body that actually sets the official screening guidelines in this country, has already recognized and addressed in their recommendations. The problem is that those updated recommendations are not always making it into the room when your doctor is sitting across from you. So let me give you the framework that will make everything I'm about to say land properly. Think of it this way. When you are 50 years old and a routine screening test catches something early, the math is clean and the logic is sound. You find a problem before it becomes serious. And IOZ, you treat it, and you potentially buy yourself decades of healthy and active living. The risk of the test is small, the upside is enormous, and the decision is easy. But 3 very important things shift after the age of 70, and these 3 shifts change the entire calculation. The first shift is this. Many of the conditions that show up on routine screening tests in older adults are what the medical literature refers to as clinically insignificant findings. These are real things that appear on a scan or a lab report, but they are growing so slowly, causing absolutely 0 symptoms and presenting such a minimal biological threat that the honest and accurate truth is you live your entire remaining life alongside them without them ever causing you a single problem. You would not die from them. You would die with them, completely unaware they were ever there. But the moment that finding appears on a report, medicine does not have a leave it alone button. It has a treat it, but ton, and that button gets pressed almost automatically. The second shift is your body's tolerance for medical intervention. This is something people genuinely underestimate. A surgical procedure that a 52-year-old bounces back from in a week and a half, that exact same procedure in a 77-year-old can translate into months of difficult recovery, serious complications, a significant loss of physical independence, and in some cases, outcomes that are far worse than the original finding ever would have produced on its own. Your body at 75 is not the same as your body at 55. And the interventions that follow these screenings do not always account for that reality the way they should. The third shift is what I want you to remember as the cascade effect, and this one is absolutely critical. One routine test finds a small abnormality. That abnormality triggers a follow-up imaging scan. The scan suggests a biopsy is needed. The biopsy leads to a specialist referral and a recommended procedure. An E-procedure produces a complication, and suddenly a person who walked into their annual physical feeling completely fine, sleeping well, enjoying their life, is now trapped inside a medical spiral that started with a test they never actually needed in the first place. That is the cascade effect, and it happens far more often than the system likes to acknowledge. Keep all 3 of those shifts in your mind as we go through each of these 5 checkups, because they are the lens through which everything is going to make sense. And stay with me all the way through number 5, because that is the one that almost nobody is talking about publicly, and based on what the research shows, it may be the most important one of all. All right, let's get into the first one, routine colonoscopy after the age of 75. I want to tell you about a woman, let's call her Margaret. Margaret was 76 years old, a retired school teacher, completely active, sharp as a tack, no digestive symptoms whatsoever, no family, and history of colon cancer, and she had already completed 2 colonoscopies in her earlier years, both of which came back perfectly clean, not a single polyp, nothing concerning at all. But when she visited her new primary care physician for a routine annual checkup, that doctor looked at her chart, did some quick math on the timing, and told her she was due for another colonoscopy. Margaret had some hesitation. She had read a little about the risks, and she wasn't entirely comfortable with the idea. But she didn't want to come across as a difficult patient. She trusted her doctor, and so she agreed to move forward with the procedure. The night before the colonoscopy, Margaret drank the required bowel preparation liquid, the strong laxative solution that clears out your entire digestive system before the scope goes in. By the following morning, she was dizzy, deeply confused, and physically unable to stand up without help. Her daughter found her in that condition and rushed her directly to the emergency room, and Margaret never even made it to the procedure itself. The hospital found that the preparation liquid had hit her kidneys extremely hard. She was severely dehydrated, and her electrolyte levels had dropped to a point where her heart was in genuine danger. Margaret spent 4 days hospitalized, 4 days, and here is the part that I really need you to hear clearly. She never needed that colonoscopy in the first place. The United States Preventive Services Task Force, the official body that establishes evidence-based screening guidelines for this country, explicitly recommends against routine colonoscopy screening for average-risk adults over the age of 75. The evidence supporting that recommendation is strong and consistent. After 75, if you have no active symptoms, no family history of colorectal cancer, and your previous screenings have been clean, the risks of continuing routine colonoscopy begin to clearly and measurably outweigh the potential benefits. And though C risks are not minor or theoretical, bowel perforation, which is a literal tear through the wall of your colon caused by the scope itself, occurs in approximately 1 out of every 500 colonoscopies performed. In a younger and healthier adult, a bowel perforation is a serious but generally manageable surgical complication. In a 76 or 78-year-old, that same perforation can mean emergency abdominal surgery, a temporary or permanent colostomy bag, extended hospitalization, and a recovery process that fundamentally and permanently alters that person's quality of life. And here is the other side of the equation that almost nobody explains to you. The colon cancers most likely to be detected through routine screening in older adults who have no symptoms tend to be slow-growing cancers. So slow-growing, in fact, that the medical literature consistently shows they would never cause any clinical problems within that person's natural remaining lifespan. You would never feel them. They would never spread. They would never shorten your life. But once they are found, they are treated, and that treatment carries real and serious consequences for an older body. So what should you do instead? Ask your doctor about a non-invasive stool-based screening option. Tests like the Cologuard or the annual FIT test can identify genuine warning signals without putting your body through the physical stress of an invasive procedure. These are legitimate, evidence-supported alternatives that make far more sense for the majority of asymptomatic adults over 75. Now, I want to be absolutely clear about one thing. If you are experiencing symptoms, blood in your stool, unexplained and persistent changes in your bowel habits, abdominal pain that is new and doesn't resolve, that changes the entire conversation. Those symptoms require evaluation, regardless of your age. Go see your doctor. What I'm talking about is the routine, no symptoms, just have a safe screening in older adults who are feeling competent and eatly well. Now, let's move to the second checkup. And this one requires me to be very precise with my words because I do not want to be misunderstood. I am talking about aggressive PSA prostate cancer testing and routine annual mammography in average-risk asymptomatic patients over the age of 75. And I want to be crystal clear before I go any further. I am not telling you that cancer screening has no value. Cancer screening has saved an enormous number of lives, and it absolutely can save yours. What I am telling you is that after the age of 75, aggressive cancer screening in individuals who are average risk and completely without symptoms has a documented and serious overdiagnosis problem, and overdiagnosis leads directly and predictably to overtreatment. Let me explain what overdiagnosis actually means in language that makes practical sense. Modern imaging technology has become so extraordinarily sensitive that it is now capable of detecting cancers that are, biologically speaking, B, and airly active, tiny, extremely slow-growing tumors that, if simply left alone and never disturbed, would never spread to other tissues, would never produce a single symptom, and would never reduce the length or the quality of your life. These are cancers you would die with decades from now, not cancers you would die from. But the moment a radiologist writes the word malignancy anywhere on a report, the entire clinical apparatus activates. Biopsies get scheduled, specialist referrals go out, treatment plans get drafted, and all of that moves forward with significant momentum, regardless of whether that particular cancer actually represents a genuine threat to that specific person's life. Think about a man, let's call him Robert, 78 years old, retired, still physically active, mentally sharp, enjoying his life fully. His routine PSA blood test came back with a slightly elevated number. A biopsy was performed and confirmed the presence of a low-grade, slow-moving prostate cancer. His urolog and IST recommended radiation therapy, and Robert, trusting the recommendation and understandably frightened by the word cancer, went through the full course of treatment. Within 12 months, he was managing chronic fatigue that hadn't existed before, significant urinary dysfunction, and a quality of life that had declined in ways he had never anticipated and that his physician had not adequately prepared him for. Stories like Robert's are not rare exceptions. They are documented extensively throughout the peer-reviewed medical literature. Men who, looking back with full information, understood that the cancer found in their body was the biological kind that a man their age would almost certainly have lived alongside comfortably for the rest of his natural life without it ever becoming a serious problem. That knowledge, had it been presented clearly and honestly before the treatment decision was made, could have changed everything for him. Research published in major medical journals has found that a meaningful portion of cancers detected through mammography in women over the age of 70 were clinically insignificant, meaning that the treatment those women received provided no measurable survival benefit whatsoever, only side effects and a reduced quality of life. So what is the right approach? Have a genuinely honest and detailed conversation with your doctor about your personal and specific risk profile. If you carry a family history of cancer, if you have known genetic markers, or if you are experiencing any symptoms at all, then screening is absolutely appropriate and important. But if you are average risk with no symptoms, ask your physician this specific question before agreeing to any screening. If this test finds something, what are the realistic and honest treatment options for someone at my age and in my current state of health? And what would we most likely actually recommend doing? That single question has the power to completely reframe the entire conversation and bring the real risk-benefit picture into focus for both of you. Now let's talk about checkup number 3, and this is the one that genuinely surprises people because on the surface, it sounds so entirely reasonable. I'm talking about routine cardiac stress testing in adults over 70 who have no cardiac symptoms. Your doctor looks at you and says, "You're 73, let's just make sure that heart of yours is doing everything it should be doing." You get on a treadmill or they administer a medication that temporarily elevates your heart's workload while they monitor its electrical activity and blood flow response. It sounds responsible. It sounds like exactly the kind of proactive care you should be receiving. Here is the problem that the research reveals. Cardiac stress tests performed on people who have no symptoms produce false positive results at rates that can reach 40% or higher in certain older adult populations. That means that in many cases, nearly half the time, the test is flagged. An abnormality in a heart that is actually functioning completely normally. But medicine cannot simply note an abnormal finding and move on. That false alarm immediately launches you into the next phase of the cascade, a cardiac catheterization. And a cardiac catheterization means threading a thin, flexible tube through your blood vessels, typically entering through your wrist or your groin area and guiding it all the way into your heart. This is a serious invasive procedure with real and documented risks, including internal bleeding, damage to blood vessel walls, dangerous heart rhythm disturbances, and in rare but real cases, it can actually trigger the very heart attack or stroke that the entire process was designed to help you avoid. And here is where it becomes even more counterintuitive and more important for you to understand. If that catheterization identifies a partial arterial blockage, which is an extremely common finding in adults over the age of 70, many of whom are WAL. King around with partial blockages and feeling completely fine, you may be recommended for a cardiac stent. But here is what the research actually shows. Multiple landmark clinical trials, including the highly significant ischemia trial, which followed thousands of patients, found that placing a stent in patients with stable coronary artery disease produced no reduction in heart attacks and no extension of life compared to simply managing the condition with appropriate medication and consistent lifestyle changes. The stent carried its own procedural risks, required a lifetime of blood-thinning medications with their own serious bleeding complications, and yet statistically delivered no better outcome than a daily walk and the right prescription. So the full picture looks like this. You felt completely fine. You had a routine stress test. The test produced a false alarm. The false alarm led to a catheterization. The catheterization found a stable partial blockage. The blockage led to a stent. The stent required permanent blood thinners. And at the end of all of that, you are statistically no better protected than the person who simply optimized their blood pressure, their cholesterol, their blood sugar, and walked 30 minutes every single day. What should you focus on instead? If you have no chest discomfort, no unexplained shortness of breath during normal activity, no episodes of dizziness or lightheadedness while moving around, then routine cardiac stress testing is searching for problems in a population where problems are common, but where intervention does not reliably help. Direct your energy and your conversations with your doctor toward the modifiable risk factors: blood pressure control, cholesterol management, blood sugar regulation, consistent physical movement, quality sleep, and stress reduction. That is where the real and meaningful gains in cardiovascular protection actually live. The fourth checkup I want to address is routine bone density DXA scan, followed by automatic long-term medication prescribing. And I know this one makes people uncomfortable because osteoporosis is absolutely real. Bone loss with age is absolutely real. And the consequences of a serious fall in an older adult can be genuinely devastating and life-altering. So I want to be careful and precise here. I am not questioning whether bone loss happens. It does. I am questioning the automatic and often unconsidered pipeline that routinely follows a DXA scan result in patients who are over the age of 75. Here is how it typically unfolds. The DXA scan detects reduced bone density. Your doctor prescribes a bisphosphonate medication, drugs like alendronate or ristronate, which are the standard pharmaceutical response to low bone density findings. You begin taking them, likely for years, operating under the reasonable assumption that you are now protected. But here is what frequently goes unmentioned in that prescribing conversation. Long-term bisphosphonate use has been associated in the medical literature with a rare but genuinely serious condition called atypical femoral fractures. These are spontaneous stress fractures that develop in the thigh bone, which is the very bone these medications were prescribed to protect in the first place. These fractures can be severe, painful, and require surgical intervention to address. Beyond that, bisphosphonates have also been linked to osteonecrosis of the jaw, which is a painful and notoriously difficult to treat deterioration of the jawbone that can significantly impact a person's daily quality of life. Meanwhile, the single most effective and evidence-supported intervention for reducing fracture risk in older adults is not a medication at all. It is fall prevention. Research consistently and clearly shows that balance and strength training, Tai Chi specifically, has been demonstrated to reduce fall risk by nearly 50% in older adults, removing physical tripping hazards from the home environment installing grab bars in bathrooms and other high-risk areas, carefully reviewing all current medications for side effects that include dizziness or balance disruption, getting vision checked regularly because visual decline is a major and underappreciated fall risk factor, and ensuring adequate daily protein intake along with sufficient vitamin D levels. These practical non-pharmaceutical interventions reduce real-world fracture risk more meaningfully than medication does, and they do it with zero pharmaceutical side effects. I am absolutely not saying that bone health medications are never appropriate. There are clearly defined patients who genuinely need them, individuals who have already experienced fractures, those with very significantly low test scores on their DXA results, and those with specific clinical risk factors that make pharmaceutical intervention the right call. But a routine DXA scan result leading to automatic long-term medication prescribing for an otherwise active and healthy 74-year-old who has never broken a bone in their life, that is a conversation worth having thoroughly and honestly, not a foregone clinical conclusion that gets implemented without real discussion. Before your doctor writes that prescription, ask these specific questions. Can we first do a thorough review of my personal fall risk factors? And what is the actual measurable difference in fracture risk reduction between this medication and a structured supervised fall prevention program? Those questions will open a conversation that most patients never get the opportunity to have. Now let's talk about the fifth routine checkup, and this one may be the most overlooked of all because it sounds completely harmless. I'm talking about routine full-body CT scans and repeated imaging tests in older adults with no symptoms. A lot of people believe that more scanning means more safety, but that is not always true. Every scan increases the chance of finding tiny abnormalities that may never become dangerous but immediately create fear, follow-up testing, biopsies, and unnecessary procedures. I've seen people walk into a clinic feeling perfectly healthy and walk out carrying anxiety over something that would never have affected their life in the first place. And remember, repeated exposure to unnecessary imaging also exposes the body to additional radiation over time, which is another risk factor most people never think about. The real goal is not to search your body endlessly for every tiny imperfection. The goal is to stay functional, energetic, mobile, mentally sharp, and symptom-free for as long as possible. That should be the focus after 70. So here's what I want you to take away from this video. Aging does not automatically mean you need more testing, more scans, and more procedures. In many cases, it means you need smarter decisions, more individualized care, better nutrition, more movement, higher quality sleep, stress reduction, and a doctor who is willing to look at you as a whole person instead of simply following a checklist. I'm not telling you to avoid medical care. I'm telling you to ask better questions before agreeing to interventions that may not actually improve your quality of life. Because at the end of the day, the most important thing is not how many tests you've completed. It's whether you are still waking up with energy, enjoying your family, staying independent, and living your life fully. And if you found this information valuable, make sure you subscribe, share this video with someone over 70 who needs to hear it, and stay with me because there's a lot more about real health that most people are never told.